Education from University of Illinois at Chicago College of Applied Health Sciences. Thank you for being here, Jean.
Thank you. All right, so this is wonderful. They told me, figure about 20 to 30, so we are packed and full house, and I have no idea who's around the corner. Let me see. And who's around the corner over here? Okay. Well, Meg, it's good to see you. All right. So anyways, I see there's a bunch of students, so thank you, Fox College. That's great. So raise your hand if you're a student. Wow. Awesome. Raise your hand if you're in the clinic primarily. All right. And raise your hand if you are in academics, one way or another, primarily. Okay. And raise your hand if you feel like you already know quite a bit about this topic. Okay.
Raise your hand if you're an alumni.
All right, raise your hand if you're an alum. That's right. Oh, thank you. Okay, so raise your hand if you have read the articles. And it's totally okay if you didn't. I just want to gauge where people are. Okay, if you've attended any of the webinars? Okay. All right, so then I think what my plan was probably on target, and that is my hope for tonight is to, I'll show you the objectives for the evening, but it's really just, I'm going to start out with an overview of the upcoming Clinical Education Summit, so it's really an exciting time in clinical education. And I guess I would say from my perspective is regardless of where all of this goes, it is just extremely exciting right now, the conversations that are happening, really throughout the country related to clinical education. This is crowded, but I still would like to keep it informal, and there are several people in this room who know as much or more about this topic than I do, so I really want to invite them to jump in. And so raise your hand if you'll be attending the summit coming up in Kansas City next month. Yeah, a few. Okay. And true to form, just this afternoon, have you seen it yet?
I have it here, and I'm trying to speed read.
I know, so was I. At 1:30 this afternoon, we actually just got the email from IPTA, from Lisa McLaughlin, with the schedule and whatnot for the summit. So for people even who have been following it, that's kind of been a bit of a mystery and sort of an evolving situation. So I put my final touches on this about noon today, and then I was running from work to come here, and I had to check an email before I could leave, and I saw that email. I was like, oh my goodness. I'm like, I better look at this before I come here. So I have a little bit to share, and Becky might have time to process it more carefully. The reason why I passed out sticky sheets to you, and I asked you all to take 3, and there will be more going on, and we're a little bit crowded to have you come up and put it on your own, but Julie and Corey's over here, maybe if you want to raise your hand, and Julie have offered to be runners, and so you might need to label it. But the point is, in terms of discussion, I'm going to give you the discussion questions that I thought of for the, toward the end first. And I say I, but really what they're modified from is at PT Next, Stephanie Kelly, who is one of the people who's been very involved with this, had done a presentation that when I was looking to see what was on the ACAPT website, the Academic Council website, there was a PDF of this presentation. And so I thought, well, these are pretty good discussion questions, and modified them a little bit. So as you listen, this is what I want you to think about. What about any of the things that we're talking about? I'm going to kind of go through and summarize the articles and some of the discussions to date. What about those are you excited about, or consistent with what you think of as best practice? For those of you, some of you are students, you no doubt have your own perspectives. For the students in the room, have you had internships yet? So you guys are earlier in the program. Okay, so you may have some kind of preconceived notions, or you may have talked to some of the students that are further along than you. But what's kind of working well? What in some of these discussions is going great? Second, and if you have things about that, what you're really excited about that you hear are best practice, it's going to go on this sticky sheet. So maybe if it would help to just label it across the top for our runners, and that'll help to guide our discussion a little bit. The next one over here is there anything in here that's uncomfortable? Any of these ideas, it's like, thumbs down to this idea. You're either uncomfortable about it, you don't think it's going to work, it doesn't seem at all to make sense with the way you perceive clinical education. And if you have any suggestions or modifications, I thumbs down to this, but something else might work, then that will go over on the top. And then that generic other. So other things that are going through your head, whether it be questions or comments, and then we can just kind of see where people land, and we'll have time for an open discussion, or we can, if there's clusters of topics, we can look from there. Fair enough? Okay. So am I on target then? My hope for this evening was really just I wanted to see where people were at, and I think in terms of where a lot of people in this room are kind of learning more about these issues. These are the objectives that I had come up with. So let me know if you agree that we're on target. So what are the purposes of this upcoming summit? That would be a big one. Why are we even having these discussions? What is it that we think maybe should be different? What is some of the recent literature findings related to quality or best practice in clinical education? So actually the first article that I chose for us to talk about is by two of the authors that have contributed to these 7 articles, but actually was published earlier than that, back in 2013. The APTA, the House of Delegates, and Becky, I hope you can maybe speak to this about what happened at the House, and that was there was a best practice for physical therapists clinical education. And a copy of that motion you have as well. It actually does a really nice job of giving you some of the background, thank you, information related to that. Then we'll talk about, just real quickly, the key components of the 7 papers that are in a special topics issue of the Journal of Physical Therapy Education. And then really, hopefully the heart of what we're going to do and talk about, what are some of the opportunities and challenges toward attaining a shared vision for clinical education. That's really, maybe some people in the room think we have it already, but there are other people who think we need to just kind of knock down what we've been doing all these years and almost, some people would say blow it up and start over. So what is best meets the needs of all our stakeholders. And in that regard, the intent of that shared vision for clinical education. So this is where it's going. The hope is to reflect the contemporary practice setting. So part of what's driving it is a sense that practice has changed, and reimbursement for practice and settings have changed to promote excellence in clinical education experiences, to be sufficiently flexible to recognize individual program variability. So, the intent is not to create a cookie cutter curriculum or cookie cutter clinical education that everybody would be obligated to follow, but rather what are some of those common threads that all programs should emulate, and similarly where might that variability continue to be okay. And finally, to produce that shared vision that the majority of stakeholders can endorse. So the end goal of the summit is to kind of come up with a consensus document, consensus about what should we be doing moving forward. In that regard, I just wanted to show you a photo of one of my favorite stakeholders, and this is our class of 2013 from UIC. So, it's really great that we have so many students in the room because you are obviously a huge stakeholder in this. This is our class of 2013, so there's actually a few people in that group. One of the current minimum qualifications for clinical instructors is to have at least a year of experience, and so there's actually a couple of people in that group that have served as CIs already. So that's one group, and you can think of others, but certainly the patients and their families and our all of us as physical therapists or physical therapist assistants, our insurance carriers, our facilities, all of these policies driving change. The APTA, vision statement obviously is huge, and as you've seen, I'm sure everybody in this room knows of that, and so as we've gone from Vision 2020 to beyond Vision 2020, there's really been that shift toward the individual physical therapist. Those values that were identified in Vision 2020 certainly are still very, very appropriate, but as well looking toward, concepts that really go beyond out into the wider community. So what are the impacts of that related to clinical education? So these are all the articles. If you haven't already, the articles are available. ACAPT is the American Council of Academic Physical Therapy, so acap.org is their website. If you go to there, you can actually link over to all of these articles. If you are a member of the education section, you would have gotten a special supplemental issue that came out. I think it finally came out earlier this summer. So all of the articles are in there, and then what many people in this room took part in was a series of webinars that took place over the summer. So there were, I think, 6 webinars revolving around, there were like 2 webinars each geared around 3 different topics. So they kind of paired off the different articles, hosted the webinars, and there were usually about a couple hundred people from all over the country that participated. Those transcripts are available, and actually in the stuff that came out today, Becky, if you had a chance to read it yet, there's actually a really nice summary, I think, that does a pretty nice job capturing some of the spirit of those discussions and, where people might have been in pretty strong agreement or kind of hesitant maybe, or other ideas that were more shot down. So the Educational Leadership Conference, which is down the bottom left there, that is, happens every year on an annual basis, usually over Columbus Day weekend, and it's typically a 2.5-day conference, which this year has been shortened up into 2 days. So on Friday, Saturday is the ELC conference in its pretty typical format, and then immediately following that is the Education Summit on Sunday and Monday. So there'll be many of the same people there, but this is really the coming together after all of these articles, after all of these discussions, after all of the webinars and whatnot. So, one of the purposes of tonight, and it's really great to know that there's some other people in this room too that will be in the summit, is that, we're really going to represent, there are 2 people from each academic institution that belong to ACAPT who are invited to the seminar. And then there are, I think, about another 50 or 100 other stakeholders, which include some clinicians, which include some community members, and kind of select people that'll be a part of it. But, really a lot of the input, is now. And so really, part of the sticky sheets, even if we don't get to use them too much tonight, might be to really just be, for me to look at them after, and other people that will be at the summit as well, and to think about, where are people's likes and dislikes and hesitations, and what other ideas might come up, because none of this is a done deal. Okay, so there was an article, McCallum is one of the authors of the Education Section Special Supplement, but before that she and colleagues came out with an article back in 2013. And this was about how is quality defined in clinical education, and what is the rigor of some of the articles that are out there. And so this article is cited pretty frequently throughout several of them, but I just thought it would be worth taking a few minutes to talk about it, because I had read this article, and we had the Chicago Area Clinical Educative Forum. There's several people in this room that belong to that, but it's a local group of clinical instructors, center coordinators for clinical education, and academic coordinators, where we get together on a monthly basis and talk about clinical education issues. We've had 3 of our meetings revolving around the summit, and we had talked at one point about quality and best practice in clinical education, and spent some time with this article as well, and had a chance to share this. I was actually over in Sweden earlier this spring, and did a presentation with some colleagues there. And I guess what was striking to me, maybe not surprising, but still nice to see, is that there are a lot more similarities in clinical education internationally, at least based on my limited experience over there, as there are here. One of the key differences, though, is that clinical instructors are called tutors over there, and in Sweden, as in many of our other countries, PT is at a bachelor's level. So we had some interesting discussions about that as well, but way more in common. And when we talked about some of the challenges, we all kind of smiled and rolled our eyes at the same things. One of the big differences, though, is insurance and healthcare and access to care, and that's very different. But in any event, what McCallum and they looked at, first of all, it's like, what is quality? So we keep talking about quality in clinical education, and I think that's some kind of a subjective term. But here are some dictionary definitions of that. But kind of the end point of their article, so we'll kind of start with the end in mind, is that really that the evidence, is somewhat inconclusive related to what is quality, what is best practice. And so here we are, getting ready for this summit, really trying to make some decisions, as is frankly not atypical of clinical practice, is when you don't have all of the answers and you're trying to, make your best decision moving forward. But they came up with, what they 5 constructs that had 14 sub-themes. We're not going to talk about every one of them, but and then what they looked at is they searched all these different articles and looked for ones that had critical appraisal scores, 13 or 14 articles that kind of had a higher rigor and a low risk of bias. So in the end, they came down. I'll show you how they looked at that. They came down with a series of about 54 articles, I think it was, that they reviewed. I'm going to let you take a second to read this, because I think this has been, just a huge caution, guiding principle, if you would, moving forward. And I think we lost. Did we lose the last line there? Yes, do you have it on your thing?
Yeah, it's on this one.
Okay. Can I read this? Okay, so really it's a caution related to the similarities and the differences. And so, that our differences may put us in danger, but similarly staying the same may as well. Current models may not be defensible unless or until the research is better able to define and measure quality and what models of best practice should become standardized. And so there's sort of this, I really just love that quote, and I kind of think about it a lot, and I think it's very cautionary moving forward. So we talked about, again, that they'd come up with these 5 constructs. And so they were looking at frameworks, clinical education sites, structures, assessment, and the clinical education faculty itself, and had these kind of subcategories underneath. We're going to kind of fly through these. Here's kind of how they looked at their systematic review, and what you can see over here is that at the end they kind of had their strategy. They were looking at critical appraisal scores that were on the higher end and came up with 54 articles that they looked at. This is how they searched it, just if you're interested in kind of the background of their article. But again, of the 54 articles, they only found 19 that kind of met that critical appraisal score of 13 to 14. And so those are and it kind of on the right, it summarizes that for you. So when looking at clinical education frameworks, none of those met that level. Sites, 1 out of 7. The structure of ClinEd, a lot of articles about that, 10 out of 24. Assessment, 5 out of 10. And faculty, 3 of 11. So, again, there's limited rigor, even after they narrowed them down. But here were some of the key themes. First one we'll look at is international. And some of that's even interesting because there's a lot of discussion about regionalizing clinical education, and then it's like, so where might even international ClinEd fit into that? But basically, just saying is that students who go should be really solid students. There are additional challenges going overseas, and can be wonderful, life-changing, transformative experiences, but that should be done cautiously. And we won't talk about that further tonight, but at the bottom also is another useful article that came out in the PT Journal just in 2014, looking at proposed guidelines for international clinical education. So another, for people in this room that are maybe looking at that, a good set of guidelines. The other one in terms of alternative ClinEd models, and so alternative is pretty much anything that's not our traditional one clinical instructor to one student model. And so one is that there was increased productivity, an increased time in 2-to-1 models, some increased productivity, and usually what you see is, kind of students get their feet on the ground, if you would, an increased CI time for teaching and supervision in the acute setting where that was looked at. The predominant that it was positive and reasonable, and I think people in this room who are either maybe working in a 2-to-1 model or those in academia who oftentimes are approaching sites about a 2-to-1 model, is that there's still a lot of hesitation out there among people about how to do it. There are some facilities who will do nothing but I think I speak for most of the people in this room who set up internships, is that it's still more the exception than the rule that to have a 2-to-1 model. But of course that's one way to meet some of the shortages that we often speak of. You can see some of the advantages there. Anyways, that some of that may vary by setting. It's not necessarily more or less preferred. It's just kind of a different. And I would say among our students that have maybe had over the 4 internships that we do at UIC, where they've had maybe opportunities to experience 2-to-1s, 1-to-2s, 1-to-1, different types of models. They all have pros and cons, right? So then one isn't necessarily superior. So, the bottom line is that nothing truly emerges as more superior. Then they looked at sequencing, productivity. So this is not surprising that if you have students who kind of come and go like once a week, it's hard to ever, make it that different. So we'll talk about it when a student starts, and on the front end, there's usually a drop in productivity. But as a student becomes more confident and progresses, there's usually a makeup of that. That doesn't happen if they're not full-time internships, and that's not too surprising. There may be decreased fear of failing, so there may be a camaraderie. I think sometimes we see the opposite, where there might be a competition and sometimes some insecurity, but at least among students that are of similar levels of confidence and skill, oftentimes there's a real supportive relationship. And then there's a big discussion about simulated learning experience. And this is, I think everybody's intrigued by that concept, but is that, might we, for programs that are already using some simulation, is it sort of an addition to, could it replace some of our formal internship time, particularly in more challenging settings? And so one of the discussions is that, it might, as long as it doesn't go above 25%. So I'm not sure where that 25% came from per se, but it's kind of a conservative number about, could it be implemented as an alternative way of learning without compromising. Standards, looking at, might there be standards in terms of format and length and breadth of clinical settings. And one of the things I guess I personally was really happy to see is that in the webinars, it came out really strongly. There's been some discussion about, if you spend more time in one setting, would you have the same outcome of spending the same time or shorter time in several different settings. And in general, there was, I would say, widespread agreement overall for multiple settings. And I think in most places that the different programs do it differently. At UIC, what we have is like acute, rehab, and outpatient internships. I know some do like acute and kind of a day type, an outpatient, and then an overnight, so they might kind of combine acute and rehab. So it plays out a little bit differently, but typically that outpatient ambulatory care setting, we define rehab pretty broadly. It might be that traditional, inpatient rehab setting, but it also might be skilled nursing or school-based or home care, where the focus is kind of on an interdisciplinary team model. So it's partly about settings, and it's partly, sorry, it's probably hard to hear with the traffic behind you. It's partly about settings and partly about team models of functioning. Standards for clinical instructors, there are some minimal standards, but there was also a lot of discussion, and I felt like some traction about, what does a high quality clinical instructor look like? How can we support that beyond the basic and advanced CI credentialing courses that we currently have? Are there other models that we can use to train and support our clinical instructors? And in many cases, could people be linked more directly to the academic program? Looking at outcomes for clinical education, so having actual competencies that people would progress through, and then finally the clinical facility for education credentialing. So not just the individual instructor, but the facility as a whole. So student assessment, but critical reflection, not surprisingly, right? So these are some key findings. We'll go through critical reflection enhances learning. Students, and this is really important, and everybody who's been involved in this, we know this, is that it's much easier to confront and deal with a student who's having kind of a learning problem, a cognitive issue, if you would, as opposed to a professional behavior. It is much harder sometimes to pinpoint and to quantify, and sometimes, frankly, they have the courage to confront, a professionalism issue. But those can be the ones that just get so sticky out in the clinic. So this particular study, and there's actually two Northwestern studies here, so this one by Karen Hayes and colleagues, and then the next one below by Bill Healy and colleagues, where 4.7 times more likely to get feedback in relation to a you're nodding. What are you thinking about?
Nothing.
Okay.
I just through my experience in the past and now, I reach out for help continuously, just ask for it. And it's more about, as a student, if you just sit there listening over and over, I mean, you don't get as much feedback, but as soon as you go to all the professors and you ask, is there anything I need to work on, then you get the feedback right then, and then you improve. That must be nice.
Yeah, but
It is. It's always good feedback.
But
We don't get
you don't get any. I know different. Then Bill and colleagues, they talked about how some of those barriers to deep learning, right? And we know that like heavy workloads, it's hard to learn if you're just trying to get through the day. That's true whether you're a student or out working full time. That the fast paces, sometimes you just don't even have time to stop and think and to really process. Supported active doing and really keeping that big picture in mind. So, I think really what's the end, working backwards from that endpoint. Talked about web-based programs. So I know a lot of you, probably are used or have used in the past is, we use Blackboard and do some case discussions and just updates while students are out on clinic. And then Jetty, who's also one of the authors within the articles, looked at student behaviors and what's entry-level clinical performance. So this is a slide from one of her articles back in 2007, and we don't need to spend a lot of time talking about it, but it is a great article. But what it talks about is all these different components. Do I have a pointer on this? I don't think so. Okay. Related to attributes of what's entry-level performance. So, without worrying too much about the relationship of these, I think does any of these strike you as unusual, that at the heart is clinical decision-making. And around that is your clinical skills, your knowledge, and safety. Professional demeanor, interpersonal communications are also essential. Self-directed learning, that's really the ultimate goal, is to graduate that lifelong learner. And that, the goal at the end of an internship is not that somebody is independent 100% of the time in every situation that they're going to run into. That doesn't even describe somebody with 20 years of practice, but more kind of what's referred to as a mentored independence. And, we often call at or near entry level, or even within the CPI, they'll talk about, what's independent? Well, you're independent with simple patients, and simple, is kind of another one of those somewhat subjective terms, and, significant, usually with complex, but you're still seeking feedback, and most importantly is recognizing when you need to get that feedback versus just plowing ahead with a different plan. And then there's kind of that gut feeling. And so at the end of the day, we can have the CPI, there's a PT version, a PT assistant version, and the PT assistants in the room, are you familiar with that yet? The clinical performance instrument for PT assistants? Have you seen it yet? So it might be too early in your curriculum, but there's a kind of a sister version that came out to the PT CPI, and clinical instructors will talk about kind of that gut feeling or that litmus test or the would you want this person treating your loved one is oftentimes how some people think of it. But ultimately, being objectively supporting that gut feeling. Clinical instructors, so expert CIs, there's been a lot of work done about novice to expert clinical instructors seeking educational opportunities and mentorships and building relationships, teaching and learning, and that reflective practice. So that being one of the real hallmarks of reflecting, in the moment, but also after the fact. Most CIs, this is good to know, consider themselves to be competent or very competent. That's, we would hope. To foster learning, CIs, they need time to make room for the student and to encourage that participation. So RC 1314, so we're going to move away from the column article and look at RC 1314, and this was at the House of Delegates this past June, and Becky Wojcik was one of, is there any other delegates in the room besides you two as well? All right, so please speak more to that than this, but I gave you a copy of that. But kind of concurrent with all these discussions that have been happening is that our California and Oregon colleagues came up with this proposal, I think really to keep clinical education, at the front of the association and not to let it kind of slip, into small subgroups. And so there's a lot of detail and there's a lot of wonderful background information, and I don't know if either of you want to speak to it. It passed. I don't know too much the discussion that happened. Do you want to comment at all?
I don't think there was a whole lot. I think we pretty well vetted it. It was pretty well vetted before we even got there, that everybody had kind of come to agreement, so there wasn't a lot of.
Right, and people are hesitant to kind of say no to anything about clinical education. How can you not have clinical education? It's so integral to learning. And so I think there was good agreement. There wasn't a lot of discussion.
Okay.
Well, and it's always, there's, when it's like, okay, we want them to investigate, okay, well, what are we going to do with this? So no decisions were made that this is what we're going to do. And that's where you get kind of all your controversy, is once you decide that, oh, this is how we're going to change it. Right now you're kind of investigating to figure out, okay, what is going to be, how might this look to get best practice that we want. And so that makes it a lot less.
Right. Well, and the first motion that came out, do you remember the first one? We don't need to dwell too much on that. It was kind of withdrawn or rewritten or whatever it was. But the first one, actually, I would say was kind of advocating for a particular model. And it was withdrawn, I don't know if that would be the right word, and replaced with this one that really just is much more open to, it's more asking for people to report back and to really collaborate and bring back by the 2017 House of Delegates. So the final motion that I, it was, like you said, it was a little bit hard to argue with. It's more philosophical. It just says this is important and we want to keep apprised, and there's multiple things that are being considered, and as these discussions move forward, let's continue to identify that best practice. So what meets, best meets the needs, and coming back with a report. So everything, the outcomes of the summit and what will happen subsequently will continue to be in the forefront to the House, as it should, I would argue. So in any event, kind of minimally to be included in that, you have these are the bullet points. So what are the current models of PT clinical education, both professional through postgraduate? So would not only just be kind of our entry-level trainings, but also residency and fellowships, so kind of the full spectrum, and they talk about also our clinical specializations. Mandatory postgraduate clinical training is one of the discussions that are out there, potentially stages of licensure. People are talking about, like our speech colleagues do right now, you may or may not know, is that our speech colleagues, they graduate and then they do a clinical fellowship year. Versus, what we do obviously is we graduate and then people become licensed, and there aren't great, graduated licenses. So some of that is being discussed. Findings from related studies and conferences. So really, saying it's not that we want to mimic other professions, but let's make sure we really understand the pros and cons of the models other professions use, and move forward and integrate that and come up with our own set of best practices. So this is the first article, and I just have, kind of a few slides, 1 to 3 slides, I think, related to each article. So we're not going to go into any of them in depth, but just to give you a flavor of what was discussed. So this first one was by Diane Jetty, and if you remember, she was one of the authors of that earlier diagram that looked at, what is kind of quality. And she looked at structure, processes, and outcomes, and talked about, well, can we agree? What are some of the standards? What might be some of those key components? So in structure, the number and the duration of experiences, timing and sequence, clinical education faculty, the settings for experience, various supervisory models, and financing models. Right now, as many of you in the room know, and all of us that have been clinical instructors over the years, you don't get paid to be a clinical instructor. There may be some incentives and thank yous and that, but you're not. It's kind of considered part of your job. Facilities typically, you value the, that kind of that obligation to bring up the next generation. Well, not all. Sometimes we're in a position of having to defend. Especially if your productivity is less related to having a student. To defend that against, the many other challenges that everybody's facing in terms of reimbursement and such. Then she talks about processes, so oversight, matching sites and students, some of the legal protections, and one of the things that, I just would so love is she talks about, she says, well, maybe it's a little bit naive to kind of have a universal contract, which would make the lives of so many people in this room, actually all of us in this room, easier, because, even if you're not directly involved in the contract process, you're affected by it. And she says that may be a little bit naive, but maybe we could just agree on a universal template. And so that would help. Supervising methods and then performance evaluation. So right now, the CPI is used by most programs. It has gone through a set of revisions. The most recent version that isn't, for the PTs anyways, isn't from 2006. There's never going to be the perfect assessment tool, but what are some of the things that we use? How do we evaluate students? And then for outcomes. So what are those expected competencies? Is entry level the way we currently define it? Does it really reflect the practitioners we're trying to graduate? And then, of course, costs. Next article with HECM was application of educational theory and evidence to support an integrated model of clinical education. And it might be worth spending a little bit of time and to talk about some of the definitions that came out at one of the ELCs, I think 2 years ago. And people that were at that particular ELC, there was a lot of discussion about how to come up with some universal language that people would use in the articles moving forward. And so they talked about integrated clinical education, full-time clinical education experiences, and then clinical internships. And so integrated was meant to be those not full-time, so just those short experiences, some of those half-day, one-day, whatever they might look like, that are embedded within a course. And so for us at UIC, we have an integration and assessment course where the students go out once every other week, and they, in their second year, and they work with a patient. In many of our courses, we might have 1 or 2 kind of integrated experiences where you go. Of course, I teach this fall, or co-coordinate applied pathophysiology as one of the experiences. There's a few observations in intensive care and wound care, but also a hands-on patient evaluation that students do with an instructor, and there's a project that follows. So those would be examples of integrated experiences, as opposed to a full-time clinical experience. And that would be something that occurs full-time, and they defined full-time as a minimum of 32 hours a week, that before somebody's completed all of their classroom or the didactic learning. And then they talk about full-time internships that occur, or clinical internships, which they define as things that take place generally at the end of the didactic curriculum. So looking at our UIC model currently, I would say, again, some of those integrated experiences that I mentioned. Then at the end of the 3rd semester, so at the beginning of the 2nd year, students go on a 2-week internship, but they still have another full year of classroom learning, so that would be an example of a full-time clinical experience. They're not in other classes, they're out for 2 weeks. Northwestern does that as a 3-week. Becky, what do you guys do?
We start with a 5-week practicum after the first year of the curriculum.
Okay.
I guess you call that integrated because it's not at the end.
Right. And what about you guys?
Midwestern. Oh, is Corey there?
Well, I mean, there's different models, and we all do it a little bit differently. And one of the things we do, and boy, really kudos to some of our PTA cogs. The PT, Illinois programs for several years. We get together with a calendar. So one of the things we hope helps our sites is to send out a calendar of when all our various internships are. And the PTA programs, of which there are many more, are just recently completing the same. So now that'll exist for both, which is great. But in any event, and then Heather has been involved in a lot of integrated clinical education, at Rosalind Franklin. So, different models where, we kind of have periodic ones that an instructor does, and I think yours is like weekly for several weeks throughout a course. Okay. So lots of differences, but the point is they occur earlier than later.
I'm a CCC for University of Chicago, so I deal with almost all of the schools you mentioned, with contracts and students and everything. Is there, just in the discussion, because I'm kind of new to this role, a conversation to make programs a little more streamlined and similar? I mean, I know I went to school in Boston and had my clinicals in LA, so I experienced the different breadths of programs and how they organize it. And from a CCCE role of when I get these students that have had a year of education and do a first-time clinical versus the ones that come out a little later to do their first one, they succeed a little more, I've noticed, again, based on their knowledge base. But I know the OT discipline has kind of worked towards getting clinicals in a row and similar start dates, like everyone starts January 5th for their level 2s or those things. Is there any discussion to kind of help wrangle in some of the programs that
So I would say there's a lot of discussion, and then people get scared, I think, is that, that kind of variability is like there isn't the intent isn't to make every program kind of cookie cutter.
There's so much variability from the West Coast to the East Coast because we take students from all over there. And I will say there are different levels, and I don't want to say quality of the student because that's not a judgment on, it's just where they are in their curriculum.
Right.
But it is a challenge to kind of meet the needs when you are working with so many schools that vary their programs.
Right.
So much, and also the organization of the curriculum is different.
Right.
And I took anatomy at a different time than some students are taking anatomy, and just again program based. So I just didn't know if there was some kind of
and I'd say that
uniformity.
sentiment was very much expressed. I think people aren't quite sure where to go with it or where that happy medium is. But, like I know here in the Chicago Area Clin Ed group is our DC group, we meet periodically throughout the year. And the Chicago Area Clin Ed Forum, one of the things we've tried to do to make it a little bit easier is the student information form, which I think many of you in this room have filled out or received at one time or another, is, have kind of worked with that or come up with the calendar or attempted to do things. But I think there was definitely a strong voice about some more of that would be helpful. And some of the models potentially address that. But, again, no decisions have been made yet. So making that desire known is really helpful. So looking at, kind of integrated, this is me editorializing, but so we came up with those 3 definitions, right? An integrated experience versus that full-time, non-terminal internship. Those were 2 distinct kinds of experiences. But I feel like, and everybody in this room who's read these articles, tell me if you agree, I feel like that distinction got lost in the articles, and they kind of get blended together. So, when people talk about integrated, by that definition, it would be those kind of embedded. And yet when you read the argument for it, a lot of it is about, having some of those early experiences that students can build from. You don't know everything, but you go out in the clinic, refreshed, and you can apply, and if you communicate well with your facilities, they understand exactly what that student has had and not had. So some really variability, but anyways, to really reinforce those didactic concepts, those 3 components of the cognitive, affective, and psychomotor domains of learning, transfer and applications, and again, really reinforcing that it's authentic. And we can mimic that in the classroom all we want, and you can have simulated settings, and you can kind of practice on each other, but at some point it's just not the same. It might be a fine place to start, but eventually you need to have those real situations. And sometimes some of the big challenges is learning to react in real time, right? You kind of walked into we have a student right now, she walked in, she's got her plan down, she knows exactly what she wants to do, and if she gets thrown a curveball, she's really thrown off by that. Well, and it's hard to sometimes, you can kind of, again, mimic those, but real life practice, they happen all the time. So it really applied theoretically. It was saying, this is really sound theory, that this is a good way to go, that experiential learning, talked about by Dewey, or that self-directed adult learner, and experience, perception, cognition, and behavior of Kolb. So those being kind of 3 of the key theorists that really, that this is really important. So they're not necessarily either or models, but the question becomes, what is that right balance? How much can we standardize toward the same outcomes? Then there's this concept of the year-long internship. Go ahead, you had a question or comment?
Yeah, so when you said you were talking about the students that had like the curveball,
Mm-hmm.
when do you find that your clinical instructors are normally taking off like the training wheels and letting them kind of running with the patient, I guess?
It depends a lot. It depends a lot. But I would say we always talk about, like in our 12-week internships, we'll say how the kind of the first 3 weeks are kind of the honeymoon period. That if things are not going well after for the first couple, 3 weeks, you're kind of getting your feet on the ground and people are thinking, okay, they're just getting used to it. But if things persist beyond about that 3-week mark, that doesn't mean you're fully independent in 3 weeks, but that's when the red flags start to go off a little bit stronger. But some of that's a learning style, right? Somebody who really wants to observe first. And so, sometimes when we're looking at problems with that, there are some students who might panic if they get thrown in right away, and other students who thrive on that, after some minimal orientation. So sometimes it's a learning. But anyways, the year-long internship, and without dissecting this slide too much, there's various models where the different shades of gray just represent. A year-long internship could be a year before graduation. It could be you graduate at some point and then continue on, kind of like our speech colleagues do. So different models that shift that and potentially talk about some payment. This is one of the concepts I would say that didn't get, although it's actually being used in some parts of the country, as a whole didn't get a lot of traction in the webinars. A lot of the hesitation I think was around, the point is you're like a year in one setting. So being a year at some place like UIH where you could rotate between acute care and rehab and pediatrics and outpatients, you can have a pretty good diversity of experiences, but would spending a year in an outpatient, in a very, in a musculoskeletal outpatient facility, or a year in a school-based practice, whatever it might be, is, would you get that well-rounded experience, and are there enough opportunities, where you could have something different? So that's one of the models, and there is some talk about, like after graduation, where students would potentially be paid, but at a lesser rate than somebody who was fully graduated. So here again with this year-long internship, this just looks at who are those different stakeholders. So, the student, the program, the clinical facility, the profession as a whole, and healthcare and everybody involved in general. Again, looks at some of the rationales for it, and you can kind of look through that on your own time, but some of the, again, the arguments is just that it's time to build knowledge and skill. It for facilities, a lot of times if you have a lot of short internships, as you're always getting started, and that meeting some of the financial challenges is to have a student there and really give them an opportunity. There was often the term used of having them move beyond entry level. If they're there for a year, they can move beyond entry level. And my personal struggle with that was, well, the goal of entry-level education is not to get somebody beyond entry level, right? When it happens, it's wonderful. But, are we changing? Are we talking about changing? Should we change how we define entry level? So then there's a discussion about physical PT education networks, and this gets at a little bit about what you were talking about again, is that there's so much variability. That UIC, we talk about, we have the students who want to travel, and then there's the students who potentially have to travel. At any given time, I feel like we have about a third of our students in greater Chicagoland, which is kind of Chicago neighboring burbs, another third in Illinois, and about another third who are out of state. Might mean Alaska, Hawaii, it might mean, out of state in Indiana, so that kind of varies a lot. But, we do it, and we value. And I think, sometimes there's practice variations around the country that many people value, but on the same hand, there's a lot of discussion about fragmented services, and might education networks where programs work with a smaller group of programs allow people to really, know and guide and design those opportunities. So what this shows is the changes in clinical education over the years. So you can see on the left in 2002, we're right around 30 weeks, and now the average, I believe, is about 36 weeks of full-time clinical education experiences, and you see the darker gray refers to some of those part-time. So, as we've gone, and this is physical therapy, and I don't know if anybody wants to speak to physical therapist assistant education. Has there been a change in the number of clin ed weeks a lot, do you know? I don't think so. Okay. Of course, one of the hot discussions within is the whole, yeah, which is still ongoing, right, as I understand it?
Not anytime soon.
Okay. But that discussion's there as well, and that might well change, right? That's really when there was a big change in physical therapy, is that is all but, I think it's all but one program now has moved to a DPT, is that there's been usually an increase in clinical education weeks to go along. Here's a look at networks, and this is kind of a confusing slide, and we won't spend time trying to figure out all the circles, but the point is that a program might affiliate with a key number, send a majority of students, or a facility might say, we're going to take, we will take students from these 3 academic programs, and maybe occasionally you take from somebody else, and maybe the majority of our students would be at certain facilities with a few going elsewhere. So the point being to have these networks and relationships where the argument is that quality would be a lot more consistent, be better defined, that you could really grow your clinical and academic faculty. Some of these regional core networks, again, it looks, this is kind of similar to the education network model, but it still has academic programs kind of managing those relationships. But one of the discussions that I would say, there was a lot of people saying, oh, that would be so good, but it's hard, at least for me, hard to envision how it might happen. But there's discussions about having a regional clinical education structure. So rather than every program having their own individual relationships and their own sets of contracts, there would be kind of a regional office that would manage all of that. And a lot of people, people doing, I've been DC now for my 6th year, but people have been doing like, oh, that would be so wonderful. And anybody, who does spend a lot of time in clinical education, as sometimes we spend a lot of time just trying to get enough sites, and especially in acute and rehab settings. And I know these people in the room that, it's kind of a universal challenge, and that you spend a lot of time just trying to get people places and don't have enough time. It's good to see you. And you don't have enough time to, sometimes do all of their teaching. I mean, at the end of the day, we'll talk about it, at UIC, is that students have no place to go Monday morning. Not too much of what we do really matters. But the clinical teaching and developing, dealing with student issues and developing sites and CIs, we could have, potentially have so much more time if we weren't spending time, again, just making sure we had enough placements. And sites too, you're new in your role, but I don't know how much you probably already have experience. Can you take somebody we really, really need, whatever. And so, that happens a lot on both ends. And so could there be that regional structure that would help to streamline some of the challenges and the differences and foster more uniformity? And then Recker-Hughes, the essential characteristics of some of that, what they're looking at, I think it goes a little bit back to the McCullum article, is, what are some of those basic qualifications of clinical instructors? Is our, right now, the bare minimum is what you've been out for a year, that you want to have a student, and that you're ready to have a student, which is, again, sometimes who decides that? And some people would say, well, that's not very rigorous criteria. I mean, there's certainly very much a sense so that at first year of practice, people are really making their own transitions. So, but could we define more, go even further than the clinical instructor basic and advanced courses that are, right now? And here's a list of some of the kind of those key characteristics. What might that look like? How might we standardize it? How could we foster it? With the caveat, and I was really happy to see that captured in what Becky's reading, with the caveat of, maybe we want to, grow the quality of clinical instructors, but at the same time, we don't want to scare people off thinking they're not good enough to be one, right? And so there's, really that careful balance there. Dusinger and al. Talks about some of the contemporary expectations, and I think one of the biggest things that highlighted there is that, interprofessional education, we've always, worked hopefully collaboratively and with other disciplines, but that is certainly much more the focus than it ever has been, and that there's, and with more and more people with inpatient length of stays getting shorter and shorter, is that, needing to have more and more experiences that reflect kind of the true nature, community health experiences. Really looking at chronic conditions and that full continuum, and that maybe it's time to rethink, kind of our traditional acute rehab and outpatient, and maybe it's time to rethink a little bit, maybe there's somebody besides a physical therapist, clinical instructor, or physical therapist assistant instructor that you could be working with and learning from. If not all, maybe not all the time, but at least part of the time. And people get those experiential opportunities, but not necessarily, oftentimes very formalized. So looking at, again, really pushing that into disciplinary, and Corey just did a talk with us, a really nice talk earlier this month about interprofessional education and some of these standards that if many of you are probably familiar with or will be becoming familiar with. That accountability is really huge, and so we really have, just like our clinical outcomes is our education outcomes as well. We need to try to better define. All right, and so that's kind of a highlight of those articles, and I just want to thank, first of all, thank you a ton to IPTA for inviting me to come. My colleagues, the faculty, staff, and students at UIC, we're spending a lot of my time at the Chicago Area Clin Ed Forum, and again, it's a wonderful group, and anybody in this room is absolutely invited to join. I hope you will if you're not a member already, but really hope to grow and foster this, and just a big shout out to the just my fellow DCEs at other programs, and Heather, who will be our new incoming DC at UIC as well. Joe Thamig is one of our DPT students from the class of 2016, and it would be remiss of me not to thank him for helping me with some of the skeleton save me some time by getting some of the skeleton of this going, and really to all of you. So there are references that for everything here that you can look at if you needed contact info. Thank you. One of the things I learned in Sweden was how to say thank you in Sweden, which is tack. Okay. Has anybody been doing any stickies? We can have a more general discussion for sure. That's really what I want to do now, is just to open it up and get your thoughts. And again, these were kind of we can talk about it many levels, but I thought these were kind of probing questions that Stephanie had come up with. So, of what you've heard, what do you like? Or what are the thumbs up, what are the thumbs down? Or anything else that's going through your mind. And I appreciate what you... So first of all, does anybody have any sticky sheets they would like to pass? Or questions or comments? Becky, you want to comment about what you've been perusing?
I've just been glancing, trying to read through the information that they have just today sent out about how the summit is going to work. And I think the most compelling part about it is that it's going to be a lot of work. It's not going to be one of those where you can just sit back for a day or 2 days and kind of close through it. But they describe it as following the action learning method, which means identifying meaningful questions, then proposing and developing strategies, and ultimately agreeing as a group on the actions to take. So there are a lot of different sessions, and people are going to have assignments to do before they leave. And it's expected that people are going to come up with some decisions. So I don't know if I'm going to change my reservations or not.
The first day, it's like 8:30 a.m. to 9 p.m. they have us scheduled till. And,
so it's not like you can
packed.
just go and hide in the back. You're going to have, identified name tags with jobs on them. So it will be, I'm sure, quite active, and it's a good strategy to use to really come out with some concrete outcomes of a particular group when you've got 500 people trying to, think about this very important topic. So from that perspective, it is very exciting.
Is that a sticky?
Yeah, put that on an exciting thing. The format for the summit. Action research.
Okay. Good. Thank you.
Action learning, I should say.
And they kind of, they divide into two main areas. They're going to have like two sections, and you want to, do you have that handy?
The two sections are related to,
All right, when you find it, we'll come back to you.
I have a question. I know that didn't get much traction with that year internship of like the speech therapists that do that. Has that discussed how it may impact residencies and fellowships that are in place at institutions that new grads apply for, which was there any discussion how that would impact when those would be able to be started? Because usually residencies are targeted towards the new grads that want to focus in ortho or something, and then the fellowships would be the 2.5 year out for an area of clinical specialty.
Yeah. So anybody else jump in, but my understanding when it's come up, because it's definitely went through my head. I feel like, well, this year-long internship, it sounds like fellowship still feels different to me, but residency doesn't. And the response was, so I'm not quite sure how they'd all happen in parallel if it happened, but that, the year-long internship, it's still, in general, there was a lot of support for that well-rounded generalist practitioner, and kind of, looking at, again, somebody who however you define those traditional acute rehab outpatient settings, looking at the neuromuscular, musculoskeletal, cardiopulmonary, and integumentary systems, like kind of valuing, so that year-long would be with a goal of doing, that broad-based, and residency is still, kind of a tracking toward, an early specialization, if you would. So it gets talked about, but I would say it still feels a little cloudy to me. I don't know. Does anybody else feel different?
Yeah, I think I definitely agree with what Gina is saying. I think the other thing is that when these discussions through ACAP started happening, all of a sudden a little bit of a light bulb went on and said, wait a minute, is it entry level that we're trying to achieve, or is it something beyond? And so it seems like as all of these things kind of come out at ELC and then at ACAP, there always seems to be something that sort of takes me by surprise, and I was like, is that the direction we're heading? And I know that I'm not the only one who is confused about that. And that did come out in the webinars. And there wasn't a lot of support from the people who were in the webinars for the year-long internship. But I felt like there's discussion about the different models without a whole lot of stakeholder assessment, needs assessment, and all of that. I think that it's a great idea to develop the best practice in Clin Ed, but we don't know what that looks like. And so personally, I feel to say that this is it or this is it is still very arbitrary. So I hope they come up with maybe some sort of research agenda that would kind of help better develop what is best and what is not best. And I don't know that is really the intended outcome of it, but I feel like
the things that would be affected that
right.
we've, as clinicians, have tried to formulate these programs to strengthen specialties, and then not to negate them because they're so important.
I felt like the regional models had a little bit more traction, in terms of, actually it's a little bit separate, but yeah, that was one that people felt pretty uncomfortable with, I think. Would you agree?
Yeah.
Yeah.
And and what Corey said is that it's kind of like, so I wanted to start with that McCullum article, the one from 2013, because the evidence, there's certain things that come up really solidly, but then it's like, what are we trying to change and why are we trying to change it? And how do we know that, we could shake it up, but is it going to be any better? And that's, and then the year-long internship, even though it didn't feel like it got a lot of majority support, I would, as with many things, it's got a pretty vocal minority. And so, without data to support or refute it, sometimes, it can seem like, the way to go just because of the way it's being marketed, if you would, sometimes.
And I think, like, in different aspects of it are geared towards different things. So, like, the regional networks, really that's about placement and about making sure students have places to go versus the internships. And certainly there are benefits to that. And you said you were from the East Coast and you have that really strong New England consortium that is, they're very,
well, I actually work at University of Chicago now, so I'm.
But previously.
My clinicals.
Yeah.
But it was interesting. We were never guaranteed an in-state clinical in my class when I graduated 5 years ago. So I didn't have a choice. I did one in North Carolina, one in California, and one in Rhode Island, and it was just based on the contracts that we had and the number of PT schools that flood the Boston area.
Yeah.
There's no way at Chicago at similar times can it support the network of students that come out that require 36 weeks of clinical education. That's where it went.
Right, exactly. So.
Go ahead,
I
Colleen.
think the year-long internship creates a problem because now you've got an employer involved, and that changes the dynamics and who has control. It's sort of like what the physician's residency program. You become an employee, and you're what you do, or and how they structure that. You want some, obviously the schools want some input, but once you have an employer that's paying you, even if it's a lesser amount because your license isn't full and you have to have supervision or that, you kind of lose control of that. And so that's what makes, I think, the year-long internship, if you do that as like you do in speech, it becomes you lose control of that because now it's under the employer's control in a lot of ways. And so that makes, I think, that's what makes that scary in a sense, because it's like, how do we make it what we want and what we want to deliver for the student, but yet you've got an employer that they take over from there, and then it's like, okay, well, actually the school doesn't have truly control, the same kind of control possibly, and I don't know how you you work those kinds of contracts really out, and it makes it,
Right.
yeah.
Well, and then I think about, from the school's end, like how do you determine the student's ready to graduate? If you get the whole cognitive, affective, psychomotor, and we talked about, the students who sometimes when you get on real time, and it's not until you're trying to, you can do fine with one patient, right? It's when you're trying to, do that full-time caseload, that's when you start to fall apart. And so, at what point we'd have to, I think, redefine a little bit what we're just determining is ready to graduate, or people talk about kind of standardizing or determining readiness, and sometimes my knee jerk is, well, we already do that, right? We have a curriculum that every school is different, but there are a set of standard CAPT guidelines that everybody's followed and judged against. There's a standard exam that everybody has to pass, so I feel like we do have a lot of ways that we determine readiness. We have the CPI and standards that go with that. So, what is it that we think we're lacking, or proponents of a different model, what is it that we're missing or could be doing better?
And I think if you look at that one-year internship is, the way I view it that would work in my head is that, you graduate after your year and you may have some short clinicals. You sit for your exam, you have a license. So you can work, you can go out into the workforce. But having that internship gets you some dedicated mentorship when you go out into the field. And that's what I think is the piece that really pulls me towards having any sort of one-year kind of internship, is giving those students that opportunity, or those new grads that opportunity of having much more mentoring opportunities versus just being thrown into a job. And you may end up in a facility that has a lot of mentorship because just the size, just their structure, or you could end up in a situation where you're kind of out there on your own, and it's sink or swim, and you have nobody to bounce that off of. And so that's where I think it makes that.
Right.
That's how I see the internship could be really positive, because it's like, oh, wait, you have to be mentored. Some things have to be, not necessarily overlooked, but, looking at what you're doing and kind of giving you that monitor and that feedback back, so that you're like, okay, you can continue to grow as you, first progress into it. But you'd have your license, so you're licensed to practice. You already have your basic knowledge base, and now it's how you, implement, pass on that.
Because some people would argue that we're not doing a good enough, that new grad, the typical new grad still needs significant mentorship, that they're not ready to hit the ground running. And I can remember, and I think that's what you're getting at. And at some point, right, you'd still be getting to that first point of cutting the apron strings. But I can remember talking with Nora Francis, Nora Francis is one of the DCEs at Northwestern, and she's the one who developed for her DHS project the CPI training exam that we all have to take, all right? And so I remember talking with her when I first kind of got into it, because I was really struggling with this concept of, a full caseload driving everything, and I was having a really hard time with that. And I said, but, because basically if a student carries a 50% caseload, that's all they can do, then across all 18 indicators of the PT CPI, they're flatlined at intermediate. And that really bothered me, because it's like, well, but what if they're really good with their cultural competence and want to rate them higher? And she's like, you can't. Caseload drives everything. And part of what she said was, employers, because a student, again, at half a load, when you keep bumping them up, that might be when they start to fall apart, and they have to be ready to hit the ground running. And that there's a lot of pressure from employers to, ensure that what we're calling that entry-level practitioner can hit the ground running. And I think what you're saying is, that's still not 100% the case, or not 100% the case with everybody. So that's one of the arguments, in that regard.
For the one-year internship, are there rules and regulations? National regulation, because in medicine, when you start a residency, for all the programs, they have to meet the requirements. Like certain hours that residents can work, certain stuff, rules. But for PT, do we have regulations? If we go into an internship, is there stuff they can and can't do? Make us work so much.
It's not. They're not developed yet. It doesn't exist. They're not developed yet. I don't know. Do you guys know for residencies and fellowships? Are those?
I'm just going to interrupt. There are internships already happening. So we used to take students in internships, and it's not at all like a residency, like a medical residency. Someone from the East Coast
We have a outpatient ortho residency for new grads, and we have an acute care fellowship at University of Chicago.
That's
But it's
different
different,
than an
and it's
internship.
structured very
So an
differently.
internship, kind of like what Jean was saying, can happen at different points in time related to graduation. So when I was a CCCE, we did take interns, and our interns got their license middle of the internship year. So when they started, they were making a salary, but were not licensed yet. So our management had an issue with that, so we had to stop the interns. So I think, I think running into the issues of details is where it's going to kind of fall out, how it fits with the academic goals as well as the facility goals. I don't know.
Right.
I guess I do want to add, though, that for any clinical experience, even the ones we currently have, we do have some overarching kind of things that you might consider regulations, things that are negotiated in a contract between the site and the school. So there are certain protections, if you want to focus on protections, maybe for students from abuse or things like that, that can get codified in a contract. Granted, they're pretty global. You might also consider some of the student handbooks that your institutions have as describing some of these regulations or rules that people are asked to follow. And here's another protection kind of thing, that by virtue of being a student, you have some protections through your university. And if your university is accredited by like a regional accreditor, it's incumbent on them to have certain protections. I'm thinking of things like protection against sexual harassment or discrimination and certain minimum safety requirements, things like that. So yes, we do have, in general, those kinds of rules, but it's only by virtue of being a student and having a partnership between a school and a clinical site that we establish those rules and regulations.
There aren't the kinds of hours things that you're probably referring to or thinking of specifically as of yet, but PTs don't work exactly like that.
Yeah, it's not like I was saying, is there like a committee out there or a group that meets about that has all the regulations and talk about it if you want to do a one-year internship?
So we're not a program that does a year-long internship, so I would think and it's a pretty, I don't know how many are using it, but there's kind of like a handful that are kind of piloting it. So I would imagine there has been some discussion and whatnot about I don't know what that is. I haven't seen it.
The Colorado Consortium, so schools in Colorado have met to try and establish a universal way of offering internships. And they just started recently, so they're not included in the RC. But they started in the last year or two, so they, as a consortium, tried to set some standards.
And I feel
ahead,
compelled
Becky.
to answer that question you asked me about 20 minutes ago.
Yes,
I found
please.
the answer.
Thank you.
The summit is going to be organized around two primary teams, the gold team and the green team.
There you go.
That's probably
Notre Dame or what? Who's going to go there?
But the green team is going to be focusing on curricular structures. So things like the integrated clinical education experiences, the mix of settings and patient types, student readiness, expectations at the end of whatever is done. And they'll be paired against the gold team, who is called the Partnering Processes Action Team. And so half of the audience is going to be on one team or the other. And the Partnering Processes team members will be looking at standardization and support for clinical instructors, collaboration networks, regional core networks, and they would probably be the ones to tackle the question about, okay, as a consortium, do we come up with standards that we're all going to use for the same type of experience? Or do we leave that to individual institutions, be they clinical or academic institutions? So, yeah, people are considering that, but they're still kind of at this big 30,000-foot level of trying to organize and come out with some key ideas first. And then the details of how much time and some of the things that you're talking about will come in later in whatever's implemented.
So I think, one of the things that's just so striking to me, I just was laughing when that email came out while I was in class today, because it was like, oh, go figure, you do this, and it's like, oh, I probably should have done this totally differently and done a better job incorporating. But I would encourage you to read the summary that there's a consultant who's going to be running it, and she did a summary of kind of key areas within the webinars and kind of got common threads, and I think she did a nice balanced job. My quick read of it, it was like, oh, this has a really nice tone to it that we can kind of use constructively moving forward. So
And that was on the ACAP website.
I believe it's on the ACAP website. I got it through an email from Lisa McLaughlin of APTA that came out like at 1:30 this afternoon. So, but I would imagine, I'm sure it's on the ACAP website as well, and there's several links in the email, and there was a PDF attachment links over to that.
And for people's interest, the parts of the summit will be live streamed, so you could watch
Oh, really?
as they are happening. And then those live stream sections will be archived afterwards. So you don't have to be invited to Kansas City, you don't have to go. If you can watch from home. Which I think is another great move to make this discussion as transparent and open as possible.
So you can watch, but you can't give input, correct?
I don't know if you can comment during this session.
Yeah, okay.
That would probably get a little unwieldy. I mean, 500 people and comments is going to be unwieldy enough, but I encourage you to kind of watch from home. Get clinicians, CIs to sign in.
Yeah. So Megan's around. Megan, you're here around the corner, right?
No.
No, I thought Megan was. There's Megan Kennedy. I know is one of the. Oh, I thought I saw. Is going as a clinician. Clinician has the opportunity to apply, and she was selected to go. Is anybody else in the room going as a clinician? I don't think. No. Okay. I know there was a certain upset initially because it's like each program can send 2 reps, and the program potentially could have invited somebody from the clinical community, but I think what you usually see, it's 2 people on the faculty that are going, and so there was, I think, 50 slots for other stakeholders. In which case, the clinician, it's like, well, wait a minute, where's our voice at that table? And people would say, well, we want everybody's input, sessions like this, participating in the webinars and all of that, but but there's still, there's a definite, desire to kind of be in Kansas City and really making sure that everybody's represented that way. Other thoughts?
Can I ask one question?
Sure.
And I feel like I should know this answer, but I can't draw it out. So the statement was made by, to talk about clinical education and move forward with all of this. What was the driver for this? What was the initial force, or did we just decide to?
I think ACAP decided that they wanted to look at this, that there was a concern that although we had moved to the DPT level, that clinical education, maybe it had gotten longer, but otherwise hadn't changed substantially.
But there was no stakeholders that were saying we're not happy with the product you're turning out. There wasn't something bigger that was.
Not that I'm aware of. Anybody else? Patrick, Becky, Krista? No?
I'd like to talk about clinical education. That's all I know. I think it's a lot of it's coming from a lack of clinical sites to meet the needs of students.
I wonder if part of it is just the increasing number of programs that are popping up and the increasing class sizes, maybe.
Mm-hmm.
I also think with changes in healthcare, sites are able to take less students. We're seeing that happen frequently, in particular in acute care.
Is there any discussion for reimbursements for the facilities for students? Just coming from someone who is told by their manager, you have to see this amount of people, so I'm less likely to open myself up for a longer window for students because of my own personal job expectations. So if the facility was given some form of reimbursement, or I know we all, and I get comments on CE classes that are offered for our CIs, which is a great help, and a lot of us take advantage of those, but ultimately it's our management is dictating what we have to produce as clinicians, which is a result of decreasing slots for students. So I don't know if that was part of a discussion that has ever come
It
up.
has been brought up. nothing's been decided, you know.
It won't affect me, it'll just affect my boss. But
Yeah,
Yeah.
there was discussions about it at ELC last year, a lot of discussion about that, and then it was also brought up again. And there are other health professions that do pay, like in pharmacy, I believe they pay. I don't know if in medicine they pay or not. But there are certainly pros and cons to that, and so they really need to think about what would the impact be before we move in that direction. There are some schools, I think, I don't think locally, I don't know. Krista, you might know better because you would take students from all around. Was anybody paying?
Yes, they would send me W-9s, but I filled them out because that wasn't part of our mission.
But one of the concerns with that is the impact on tuition, and we really, are try to be mindful of what students are having to pay, and so I think that that's also a real fear and concern in terms of impact on stakeholders. The other thing is that I think there might be some evidence out there that shows that just because you're paid doesn't mean you're better.
no, absolutely.
Right.
It's more of a time to maybe make them available.
Right.
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 And I think where there's a lot of discussion, so, kind of paying for a full-time internship gets a little tricky, but there's a lot of discussion about, particularly with the integrated type of experiences, is to, having clinicians, be more directly connected to the faculty. And in that regard would involve, I think some payment or compensation, or it would be part of people's jobs in that regard. But I think, the whole internship concept, I know students often, it's like, we're paying tuition to the university when we're out on internships. How's that work out?
Well, another interesting question to ask about that is who gets paid.
Yeah.
Do the clinicians get paid? Does the PT department get paid? Does the institution get paid? And what are the implications of that?
And I think that the change in healthcare is driving a lot of that as well. I know that before I left my former institution, the higher ups were saying, well, wait a minute, where is the payment in this contract? And we're like, well, there is no payment. And so we had to establish value for the education program in a different way. And then at that institution, we were able to do that because education was a high priority of the mission. So you could justify it that way. But when they get paid by one program and not paid by the other, and money is tight, they start to look for where can we generate. And so it is a real question, and it'll probably come up again. I'm sure at the summit there'll be something I'm sure will come up.
You had your hand up.
Institutions though, like it's a benefit for them. Think of how many institutions hire former students. It's an institution's chance to see clinical, I'm sort of wondering, but it's their chance to see the clinical practice and professionalism for a short period of term without making a major commitment.
Yeah.
So,
yeah. And so you might sell it on that.
yeah.
I was just gonna say.
Yeah,
with
think
the
of every
numbers-
internship as an extended interview.
The numbers were less, and there were less programs and less students per program. I think that was super valuable. I agree with you, back in the heyday. I always say I graduated in 1900, but, people look at me really, and they start to do the math. But, now that we're producing, we have more schools and more students and there's more workforce, there's more out there. Employers are sort of like, not so much. That's what I'm seeing anyway. So.
I think that's one of the things. I mean, I used to, when I started with students for a number of years, I did all 2-to-1s. It was my favorite way of doing students was the 2-to-1 model. I just found it very collaborative. They can learn. But when they switched to CPI, like you said, it made that you had to carry the full caseload. It hamstringed me. And I couldn't take 2 students because I couldn't manage 16 patients. I can manage 8, 7 or 8. But 16, and keeping track when I've got a student doing, bits of this, was way too much, for me as a clinician to be responsible for and to keep track of just from the paperwork standpoint and that kind of time. And that I think makes, that limited our sites, because it's like all of a sudden I'm not taking 2 students, each time I take one, I'm only taking 1 because there was no way that I could figure out, well, is it okay if I could prove the last week that they could do a full caseload, you know, versus having to do this full caseload the whole time they're there, or build up, you know, relatively quickly. And based on the way the CPI was written, I couldn't do that. And so I think that made a huge change in that. And I think that's something that maybe needs to be looked at in how you do grade that, you know, kind of thing. And not saying that somebody's not entry level if, you know, how often, you know, if they can, do they have to demonstrate that they can do 6 patients a day, or, you know, because our caseload is 7, and I'm like, my students only have to do 6, and I'm like, that's just my rule. And I'm like, you know, because I think that's what's reasonable. You have to be able to manage a double, but you don't have to be able to manage a double every day, you know, 5 days a week.
Well, and as you know, I mean, that's why in the CPI it has this great big bolded, what is the student capable of carrying? So it doesn't mean they have to. And I'm not quite sure if they're not doing it on a semi-regular basis, how you make that decision, right? But, you know, it's like, so in other words, as a student, you don't get penalized because the census drops. You don't get penalized because you observed surgery for half a day this morning and you still didn't see your 24 units, right? But rather that, are you capable? Can you manage those duties? Can you still get everything done and not be there till 9 o'clock doing paperwork, you know, because there's just so much to do and you can't get it done, you know, within what theoretically would be, you know, that 8-hour day.
Yeah,
So.
and I think that, like, you know, if you can get snapshots of that, and like Jean said earlier, is when they do have that full day, do they fall apart? You know, and that's really what you're looking for at that point. And I never used to buy into that either until I saw it happen. And then I was like, oh, this is what that means, you know, and when it happens, it really happens. And so, right? And so I think it's just, you know, even if you had I'm a DCE, do the 2-to-1. Oh my God, I would
but, you know,
here.
going through Nora's class,
Yeah.
you're like, yeah, you know, you do the numbers, and you're like, oh wait, they don't, you know, it doesn't quite add up, and you're like, oh, okay, how do you, you know,
but it's
to balance that.
right, but it is that judgment call, and are they capable of, and can they do it more than once in a week? You know, it doesn't have to be every day. But I definitely appreciate what you're saying, and I'm a huge fan of the 2-to-1. That was all I ever did, but I was dedicated to those students, you know, and I felt I could be a better instructor in that role because I could be there for them full time. But it can be challenging. I did a 4-to-1 once, would not do that for a prolonged period. But it's hard. It's hard
when
to
you
keep
get
all those patients in your
But if you could let the student, I mean, I found so much value in the student sitting next to me while the other student was treating and saying, this is what you see. Now, what is she doing that you like and what don't you like? You know, so you could see it from somebody else's point of view, you know, and you're sitting there watching like, oh, I would do that, or see how they responded, what would you do? It's such a huge learning experience. It just, because your hands aren't on the patient doesn't mean you're not learning. And it gives you, I think, as a CI, so much more opportunities to teach them versus, okay, you know, we got to wait till we're after they're done because Mrs. So-and-so isn't going to want to know that you didn't, you know, this didn't come out the way you planned and stuff like that because they're with the patient and stuff. So you kind of lose those opportunities, and that's what I miss the most is just the chance to have, you know, it's like, okay, now let's watch. And how would you help, you know, your colleague here? What would you do? You know, what could you, impart to them and say, oh, this is what I saw. And it's a lot less threatening because it's like, oh, hey, you did that really well. Or, you know, or they could ask, well, what should I have done different? What did you see? You know, because you're not right in there all nervous and, you know, trying to do the best you can and have that perspective. And that's, I think, what I miss with the 2-to-1s and I've been trying to figure out a model. And I think it gets back to your question is, because, you know, for a while there I was dovetailing. It's like, okay, start 4 weeks, and then, you know, get the new one in, and then so it have it, you know, kind of overlap. Well, that is nice. Well, you tell me when I can pick, you know, okay, Marquette has, you know, this 4 weeks, and then I can get a UIC. Oh, no, that's not going to work because that one's got, you know, and you can't do the math. It just becomes, you know, you're like, okay, I guess I'll just do one. Because, you know,
I'm keep going. I'm curious. Oops. Oh, go ahead.
I was going to add in another parallel development
put you on
that I
the spot?
think is significant in this whole discussion. So many times institutions hear clinical instructors say, good clinical instructors say, you know, I really can't take a student now because of my productivity expectation. Well, just this last year, too, through the House of Delegates and initiated in Illinois at the IPTA Assembly of Representatives by a motion from a clinician who said we have to take back the ownership of our what's called productivity. But if you look at it from another perspective, it's the ownership of physical therapist practice. It's only measured in productivity units. So, long story short, the House of Delegates adopted a motion crafted by delegates from Illinois that charges the APTA, I believe, Board of Directors, to come up with some tools and information that clinicians can use to help either negotiate or discuss and explain what physical therapist practice is and what the outcomes and value of practice is in ways other than units and minutes and whatever other productivity measures are currently like getting out of control that physical therapists are not, that our practice is not well reflected in. So I have high hopes for that initiative as well. And if that goes, as I think it may, we will have more ammunition to say that yes, clinical education of students is an important outcome of physical therapist practice. It's an expectation, it's an outcome, and the value of it for the facility or site is this.
And Jen Ryan's a key.
Interestingly, nobody has even mentioned patients yet in this whole. Patients as a you know, unintended consequence of clinical education. I mean, does the patient get a better outcome if it's a student supervised by a CI? Some people would argue very well that yes, the patient gets a better outcome.
I'm curious, Julie is here, wears many hats, but one of them is as a rehab manager. So I'm just curious if you have any thoughts from that perspective.
So, that's a big question. So I guess to segue from Becky's statement about managing productivity and the sites that I've ever worked at, we've not ever gotten the 2-to-1 model. So there's some folks here that have adopted that and done really well with it. But it is an expectation, and it really comes from that clinical value of what makes a good clinician and what makes a good environment. There's an investment and an appreciation of within a year, it's a goal that you can successfully mentor a student. And so if somebody's really scared about that or worried about that, you've got now this culture of people to help facilitate that. But I think it makes the clinicians better clinicians. Productivity is something that definitely sometimes suffers in the beginning or if somebody's struggling. And then sometimes it benefits with the students as well. So I think it's a give and take, but it's how you manage that. And again, I just had to disclose too, we've not ever gotten where we could embrace and get the 2-to-1 model, though there's lots of students there all the time having a CI take that. I think would take some real grassroots efforts to cobble something together and put it in place, and we've never been able to endeavor to dedicate the time and energy if we felt we could go down that road. So I don't know if I answered your question. But the culture of the place you work is a piece of that, of course, and how hard you're getting hit by the current legislative changes and what have you,
And if I can speak, because the interprofessional practice is one of those things that is in the future and the APTA recognizes that as well. When they speak about the role of the physical therapist, I think that those components, will hopefully be captured by what is the practice of a PT, and a lot of what we do interprofessionally, the phone calls, the other coordination doesn't get counted towards productivity, but it clearly impacts the outcome of what we do. And the thing is that in Canada, they do have I don't know if it's a billable code or a non-billable code, but they do have a code for that interprofessional practice and collaboration. So automatically, by being able to count the things that you do in order to make sure that the care is seamless, will get counted, and productivity should, shoot through the roof depending on the setting that you're in. And so hopefully when all of this moves forward, that idea of what is contemporary practice will be captured in that description. And I would think that it would.
So switching hats, if there's any other questions for Jean or Stickies, we're collecting all of this, and this is a great dialogue.
Well, I just want, I don't know where Sharon is. I know when we talked about a time frame, we had talked about going from like 6 to 7:15, so people had plenty of time to network. So I don't know if we should we'll wrap up the formal part and people are welcome to linger. Yes.
That sounds terrific.
Yeah. So we're happy to keep talking about it, but yeah. Yes, please.
So everybody sit up tall, take a big breath. We're going to do Mary Mastery. You've got to breathe to live, that good posture, the same stuff you teach your patients. I want to thank everyone here and applaud you for embracing this learning, being part of the process. Some of you are students. Your experiences and your feedback is valued. I hope that as you go through these, you're both introspective on your own skills and learning, but also share that with your DCE, share that with IPTA. We want to know that. My role here, I probably should have started with that, is in the Illinois Physical Therapy Association Vice President, and I'm very proud to have been elected to that, but it's your voices that I help represent with Mary Keene, our president, who's not able to be here tonight. So thank you for being here. Please do give us your feedback, and again, thank you for being such a great interactive audience.
So thank you a ton. If you have comments you want to write or stickies you want to put up or side conversation, we continue. Thank you.